Test, test. Test, test.
अरे मैं एक બીજો સવાલ હતો કે આપણે પોઇન્ટરનું શું શાકલ છે?
એક સેકન્ડ. હા અખિલભાઈ,
પોઇન્ટરનું શું શાકલ છે? Is there a pointer?
ના, આમાં પોઇન્ટરનું નથી અખિલભાઈ.
Shoot. Okay.
And હવે આપને we are actually live right now. So but હજી આવ્યું નથી audience.
Okay. We're live. Okay. But there's no pointers facility. So may mouse in tamane dekhatu.
Yeah.
Okay.
Just in case તમારે સી સ્લાઇડ્સ ના થતી હોય next, તો you can just tell me next અને પછી મેં અહીંયાથી next કરી દઈશ. Just in case અગર કંઈ glitch થયો તો.
Right.
Okay. ऑलराइट, अखिल भाई अपने शुरू करिए ऐसे. ओके. औज़ु बिल्लाहि समीन अलीम मिनश शैतानिर रजीम. बिस्मिल्लाहिर रहमानिर रहीम. खुदा ताला अली कदर मुफद्दल मौलानी उमर शरीफ ने तारुक़-ए क़यामत दराज ने दराज कर जो. आमीन. Safi Bhurani Medical Association America is honored to have Dr. Sheikh Akil Bhai Merchant to present today's webinar. Dr. Sheikh Akil Bhai Merchant is a physician scientist at Cedars-Sinai Medical Center in Los Angeles with research focused on blood cancer, immune therapies, and bone marrow transplantation. Since the start of COVID-19 pandemics, his lab has shifted to studying the immune responses to COVID-19 pandemic and COVID-19 vaccine in patients with cancer. He is an investigator in Corral study at Cedars-Sinai, which is part of NIH-funded consortium of medical centers studying COVID-19. So without any further delay, Sheikh Akil Bhai Merchant.
وبه ووليه ووداعي أستعين في جميع الأمور. أعوذ بالله السميع العليم من الشيطان الرجيم. بسم الله الرحمن الرحيم. Aziz SBMA na committee members, and Aziz Bhayono Beono. It is a great honor to present today in this webinar. And it's something that is very close to what we're doing in the lab and research, and something also our patients and mu'mineen who have cancer have very often asked about is what about COVID-19 and cancer? What are the risks? Should I take the vaccine? Is it safe? What are the side effects? So inshallah, I'm going to go through the current data, what is available, where the questions are, and try to give you some hint on some of the interesting laboratory investigations that our lab and other labs are undertaking. So the objectives of this talk are, number one, to review the clinical factors in patients with cancer that are associated with severe disease and death in relation to COVID disease. We will also discuss how cancer and cancer therapy can alter host immunity and how that might contribute to COVID-19 severity. We'll spend some time discussing the safety and efficacy of COVID-19 vaccines in patients with cancer. And I'll present an overview of the laboratory measures of immune response to COVID-19 infection and vaccination and what that might give us in terms of insights about the recommendations we can give patients. So so there's two main studies that really have given us some insight on the clinical factors associated with COVID-19 outcomes. The first was actually is at the bottom of the slide here is a meta-analysis from several studies that summarize the outcomes of patients with cancer. And the one at the top, published in ESMO, or Annals of, which is a journal of the Society of European Society of Medical Oncology, really is from a single registry database. And there's over 4,000 COVID cases in that database. So those really form the bulk of the data that we know. So from the first paper, which was a meta-analysis, this is the sort of the key takeaway from that paper. And what they did is they did a meta-analysis that described the overall mortality risk, the risk of dying if you develop COVID-19 in patients with cancer. Now, what you can see in this is a sort of a meta-analysis, a forest plot. So the risk of death for each study that's listed here on the left, on the left side of the column, is represented by the green bar, and the confidence of that estimate is the bar line around it. And you can see that there's quite a bit of variability. And if you dive into the data, that variability comes from all the things that you might imagine. What type of cancer those patients had? What kind of treatment were they receiving? And other factors which we already know are relevant to cancer mortality, like age, gender, other health conditions. But what we estimate is, based on all these studies, if you look at the very bottom, there's a small diamond, and that is the average summarized across all the studies. And that puts you roughly at around 22% mortality, which is quite significant and quite high compared to what we understand the mortality for the general population is. The second study has a lot more granular detail, and I think is probably more insightful. In that study, they have a database of over 7,000 patients, and after exclusion of patients, they came up with about 4,000 or close to 5,000 patients that developed COVID-19. Of those, 58% of those were hospitalized, and 14% of them died. So a little bit less of an estimate, but it's interesting because one of the reasons that probably is the case is that what both studies showed is that as the pandemic went on, our mortality rates dropped, partially because we probably got better at taking care of patients, but also probably because of some bias in sort of how catching some people who otherwise weren't diagnosed. But in terms of clinical characteristics, the same things that have been demonstrated in the general population for risk: older age, male, sex, being overweight, obesity, and being non-white, at least in the United States, are all risk factors for having a bad outcome with COVID-19. Cancer-specific factors, such as the ECOG performance status, that is a measure of how active a cancer patient is. So a patient with perfect ECOG performance status has no symptoms, and severe ECOG status means they're in bed most of the time with the cancer symptoms. So not surprisingly, patients with high ECOG status or poor performance status did worse. Hematologic malignancy, so blood cancers, did worse. And recent chemotherapy also did worse. There's a table which associated laboratory outcomes, which I'll show you in just a moment. And there's some very interesting insights that the type of chemo actually seemed to affect outcome. And that's actually something that's very interesting, because it wasn't simply the case that low intensity or high intensity chemo was good or bad. So for example, ACT, which is used for breast cancer, is pretty intense chemotherapy, yet those patients overall had a good outcome, while DNMT, so DNA methyltransferase inhibitors, are actually generally considered relatively mild chemotherapy, but those patients did very bad. We'll talk a little bit about why that might be. So this is a summary of the laboratory factors that were related to bad outcome. And here, this is an odds ratio plot. So an odds ratio of 1 means that that factor neither favored good or bad outcome. And if you're to the right of 1, higher than 1, so 2 or 4, then that's how much more likely you are to have a bad outcome. And if you're to the left of 1, that means you're less likely to bad. So in other words, to the right is bad and to the left is good. So it's very interesting and sort of shows where some of the limitations of our knowledge are. So having a high lymphocyte count, which are the circulating white blood cells, was bad. But having a low lymphocyte count was also bad. So anything that a normal lymphocyte count was bad. Having having a high neutrophil count was also bad, which is sort of counterintuitive because we think of neutrophils as infection-fighting cells, and really gets to the point that I think a lot of us have recognized, that the immune system is both friend and foe here. It is fighting the infection, but also in some cases is causing the disease, particularly in the runaway inflammation. So this has been borne out by, and these factors are actually, most of these are true for actually non-cancer patients as well. Having a low white blood cell count was actually slightly protective, although it does cross 1, so it would not be considered clinically statistically significant. Other abnormal values, such as having a high creatinine, meaning bad kidney function, having a high troponin, meaning heart damage, or having a high C-reactive protein at the bottom, which is a marker of inflammation, were all bad, which are sort of consistent with what we've seen. This is that table from the study, and this is really just illustrates in some ways how little we know. So this table of the 4,000 patients, very few were actually on active chemo. And when you go down to regimen by regimen, for example, this ones that were good, for example, ACT, there's only 17 patients. This is the first column on the left of the low observed mortality. Like DARA, IMID, DEX, which is we use in a blood cancer called multiple myeloma, has only 10 patients. Just in contrast, so the study we're running right now has 90 patients just on this one regimen. So really dealing with low amounts of data, but it's an intriguing sort of early look. So these patients did well on the left, and then these other types of chemotherapy are CHOP, which is associated with patients with lymphoma, platinum etoposide, which is used in this case with many cancers, but majority had small cell lung cancer, or DNMT3 inhibitors, which are DNA methyltransferase inhibitors, which are used mostly in types of leukemia or myelodysplastic syndrome. Were all very, very bad outcomes. So before we get into this, I think I need to take a little detour to talk and remind folks about the immune system. Those who are physicians this will be just a quick reminder. Those who are not or who haven't studied this will be a first glimpse at that. So the immune system is really divided into two main areas. One is the innate immune system, and that's the immune system that, by analogy, you have to really think about as your first responders. These are the white blood cells that respond to any infection or any injury or any damage, and they respond right away, but they don't respond in a very specific way. Right? When we think of having, quote, immunity, we're not talking about the immune system, because those guys are already ready to go, whether they have seen or been exposed to the pathogen or not. The adaptive immunity is sort of in many ways, the more sophisticated immune system. And that's the immune part of the immune system that is trainable, that once exposed to an infection, it remembers that infection. And so when you're exposed again, it can fight it very quickly. And the innate adaptive immune system is what vaccination is all about. So vaccination trains the adaptive immune system. So what you do when you vaccinate someone is you expose them to the proteins that are in whatever you're vaccinated against, whether it's a virus or a bacteria, and the body develops an immune reaction against it. And then when it sees that infection in real life, it's already trained, it knows how to deal with it, and it can immediately respond to that and prevent you from getting sick or have very, very mild symptoms. Now, the adaptive immune system has two separate parts. Bear with me, because this is actually very important. There's the B cell part, and the very simple explanation is B cells make antibodies. And everybody knows about antibodies, right? So if you've been exposed, I should check whether my antibodies, or did I get the vaccine? Did I make many antibodies, right? So people have, I think, a sense of the antibodies. But it's the other part of the immune system, the cellular immunity, which is by a group of cells that are known collectively as T cells, which is perhaps the more important part, or I'm going to argue that it's the more important part of the immune system. But it's actually much, much harder to study the activity. So part of the reason why we don't report people's T cell function is it's not easy to report. It's actually hard to do. And I'm going to show you actually some specific T cell, some COVID-specific T cell assays that we do in my lab to try to answer this question that we're actually actively studying. So those two parts are separate. And the reason why that I hinted at why the different chemotherapies might be relevant to think about is because each chemotherapy hits one part of the immune system in greater or lesser aspects. So in other words, some types of therapy are more active against the B cell compartment and some are more active against the T cell. And in fact, that chemotherapy that I mentioned that was really good, daratumumab, IMiD, those patients do well. Those patients cannot make any antibody. That chemotherapy wipes out their plasma cells. They do not make antibody at all if those patients do pretty well. So there's a hint that the B cell compartment, the part that we think about making antibodies, we know that those patients don't make antibody, yet they do pretty well with the disease, suggesting that the B cell component may not be the most important part. And we'll sort of get to what the implications are. I do want to say that a very interesting project that's actually a group at Cedars-Sinai is doing that might be interesting to folks here is that the innate immunity I just told you is not trainable. Well, that's a lie because all these things are oversimplification. So it turns out that the innate immunity itself may also be trainable. And the evidence of that comes from a very interesting observation. So many people have received something called BCG. They don't give it in the US, but many people who are immigrants, they receive it in other countries. And BCG is given to prevent tuberculosis. And one of the interesting observations of BCG is that it not only reduces the risk of tuberculosis in young people, but patients who receive BCG actually have lower rates of all kinds of infections. And so the hypothesis is that BCG is actually training the immune system in a non-specific way that's actually beneficial to all kinds of other infections. And this has been reported again and again across many different infections in many different countries, is that people who get BCG just do better, they live better, they have less infections because infections are the main cause of death for children in other countries. And so this study actually published by our group at Cedars, actually, because this was done in healthcare workers and we, LA being a diverse place, we have a lot of healthcare workers from across the world. So we actually were able to look in our healthcare worker cohort and show that actually if you got BCG, you were much less likely to have reported that you had COVID, or even to have titers, in other words, for asymptomatic infection. So it's a very, very intriguing idea. And in fact, in the early days of the pandemic, before the actual COVID vaccines were available, we actually ran a clinical trial of BCG boosters to try to see if we could help people against COVID-19. Those results are still coming out. In one sense, it doesn't matter because the vaccines are so good, but it's actually a fascinating thing that may be relevant to the next pandemic, because BCG seems to have this very broad effect. And there's actually several studies ongoing within our consortium to try to understand how BCG might be training the innate immune system. And it has to be the innate, right? It can't be the adaptive, because the adaptive immune system is always specific. So BCG does train the adaptive immune system against tuberculosis, but it cannot train it against other diseases. But it could train the innate immune system by just giving it practice, by analogy, or somehow giving it some experience. Okay. So I'm going to shift gears a little bit and talk specifically about vaccine response and how we measure vaccine response. So those of you remember this from your basic immunology. Why do we give boosters? Why do we have to give 1 shot, 2 shot? It's because of this fact. So this is a schema of what B cells might look like. So these are B cells, and we're just going to focus on the B cells for a second before we talk about the T cells. And what you get when you get an antigen, you get these B cells that can respond to that antigen. Antigen is anything that you can immune system responds to. So in the case of COVID-19 vaccines, that's the spike protein you may have heard about. That's the protein on the surface that all the vaccines are designed against. So an antigen is anything that the immune system responds to. So that's the term we use. So when an antigen appears, the B cells start to respond, and you get a modest B cell expansion, and you get all these plasma cells, these funny oval-looking cells that are in the column right in the middle. Those oval-looking cells are making those little Y-looking particles, which are antibodies. Those represent antibodies. What's probably more important, and people don't think about, is the cell that's at the very, very top in the center, and that's that round cell with 3 yellow antibodies sticking, 3 red antibodies, and that's a memory B cell. Because plasma cells live for a while, they make antibody and then they disappear. But memory cells live for your whole lifetime, and they continue to produce plasma cells at some low level, so you can have a low level of antibody. But mostly the antibody is produced by this burst of plasma cell growth and then disappears. So if you look on the right side, you see this theoretical curve of a primary immune response. This is representing the antibody concentration. It goes up and then it comes back down. And that's typically a month to 3 months, depending on the type of exposure. And then you get a second exposure, let's say, whether that's an infection or that's a booster shot, and your antibody titer goes way up. And that's because now those memory B cells will make more memory B cells when they get exposed, when they get more antigen, and they'll also make more plasma cells. And now instead of having 1 memory B cell, as you had in the center column, on the right-hand column of cells, there's 2 memory B cells. That's just to represent that each exposure increases your pool of memory B cells. And those memory B cells are the stem cells from which the plasma cells or the antibody-producing cells are produced. And so each exposure increases that and increases the eventual antibody titer. But the other point of this is, and everybody freaked out early on, everyone was scaring people by doing these measurements that, oh my God, the antibodies are fading. Everyone's going to get COVID again. And that's normal. Antibody levels always drop after acute infection or even after a booster. So that's just normal physiology. And so really what you need to know is how many memory cells do you have? And that's what's important. So this is a paper that was published also by our group. This was in the journal Nature Medicine. And so we looked at the healthcare workers that I mentioned. And there's a couple of things on this chart. So right now, just focus on the green dots. Okay, just focus on the green dots. And the green dots represent the antibody titer. So at baseline, most patients have very low to non-existent titers. And the units here are arbitrary values. And this is a logarithmic scale. So just know that as you go up, it goes up quite dramatically. So after the green patients are the patients who never had COVID, no prior infection. Don't ignore the pink ones. We'll get to that in a second. After the first shot, their antibody levels, you can see in the center column, reach a certain level. And they go up quite a bit. And after the second shot, you see that they go up a lot more. And they arbitrarily drew a threshold of 4,000 units, roughly, as that threshold. You see almost everyone is above that threshold by the second shot. So here's actually the first important point I want to make. What level of antibody is protective is actually not known. We might be able to figure that out by looking at the vaccine data, but that has not been reported yet, partly because these different assays are done by different labs, so they're not standard, and partly because the vaccine is so darn effective that it's hard to, there's so few people who get infected, so it's hard to know what level of titer matters. So this is a challenge in one sense, because everyone it works, you don't really need to know. But now I want to go back to the pink values. So the pink values are patients in our cohort who actually got COVID. So not surprisingly, the patients with prior COVID before at baseline, which is the left-hand column, before vaccine, they had a higher titer of antibody. They had measurable anti-spike antibody because they had prior COVID. It's worth noting that that level is actually lower than even after the first dose and much lower than after the second dose. So this is for you, Rand Paul, who goes around telling everyone, I've been infected, I have very good antibodies. So natural infection does not produce antibody titers nearly as high as vaccine-related antibody titers. Now, it doesn't mean that they're not protected, but what we know is that the antibody titers from natural infection are much lower than those generated by vaccine. But the good news, and what I would encourage the senator, is that if you get just one shot of vaccine, and this is the middle pink bar, your titer goes really high. It goes as high as it does after 2 shots, and it makes perfect logical sense, right? Because your body has now seen a second exposure. It's seen natural infection, and now it's seen the booster shot, the first shot, which is kind of like a booster. And in fact, when you get your third shot, it actually even gets a little bit higher. You can see it's even higher up there, but essentially may not be that significant. You kind of reach a saturation level where it doesn't really get much higher. So you actually might argue that there's no real benefit to a second shot. We're not telling anyone not to take their second shot, but it looks like you get a really good response. And this is telling us, really everything we understood about the immune system really is true in this case regarding titers related to COVID-19. Okay, so these are all healthy people. So what about responses in cancer patients, right? That's what you guys are here for. So unfortunately, the data are very slim. They're coming in right now. We're expecting our own data to come in the next week or two, which we'll hopefully have that published. But what we know is the only paper so far is on the left is just published in JAMA Oncology. It's from Israel because Israel was very fast in getting people vaccinated. So that's where the first data are going to come out. And what they showed, not surprisingly, here in this group it's the group on the left here, the Masarawe et al. From JAMA Oncology 2021. I know you guys, I don't have a pointer. So on the left side, you see the left column is controls, and this is the antibody titer. And you can see there's a range. And in the patients with cancer, you again see there's a range. So what's interesting is that it's not that they all were low or high, but there's a broader distribution. So in other words, it just depends. Some cancer patients got very good responses, and some cancer patients got lower than that. The average was lower, and some patients got no response. So there are some patients who aren't getting antibody response, and we know that. We've already seen that in other studies from natural infection. And then the other paper I mentioned is the Boyarsky and JAMA 2021. And that actually is not in cancer, but I thought it'd be relevant because those patients are all organ transplants and they're on very intense immunosuppression. They're getting immune suppression therapy because of their organ. And in many ways, a lot of cancer therapy works just like immune suppression therapy. And you can see that the way this chart works is that at the very first one are patients who got no antibody response to either dose 1 or 2, and that was 46% of patients did get no antibody response. In the second group is patients who got no response to dose 1 but did manage to get a response to dose 2. That's 39% of patients. And just if you remember, in the healthy people got a very good response even after just 1 dose. And then the small group, about 19% of patients had a response to dose 1 and 2, sort of more like the normal. So quite a significant portion of patients didn't. Of note, is sort of an interesting thing. People always ask us, which vaccine should we get? We say, whichever one you can get. Probably looks like Moderna compared to Pfizer had a little bit of a higher response rate in this data. And that's probably the simple reason is that Moderna is actually given at a higher dose than Pfizer. And we know that people who have poor responses, if you give them more vaccine, they respond. So like, for example, flu shots for older people, for elderly, they get a higher dose. And so that's not a surprise. It's also why Moderna has more side effects. So it's not for free. So if you're a young, healthy person, probably if you get Pfizer. If you're worried, if you're at your vaccine response, maybe I would get Moderna, but probably they're probably all okay. All right. So I talked about B cell responses, and now we're going to get sort of the fun, sort of exciting stuff is what about the T cell responses? So I have to show you this figure because T cell responses are complicated. And the reason why is T cells, because they're so very specific, need to recognize a protein, and they can't just recognize a protein that's floating around. It has to be presented. T cells are very, very finicky, and they have to be pampered. They have to be presented the protein, the antigen or peptide, by another cell. And that job of that cell is called an antigen presenting cell. That's its function. It's like it gobbles up proteins that are other things that are floating around. It chops it up and it serves it on something called the MHC, the major histocompatibility complex. It serves it like on a tray, think of it that way, to the T cell. And only if it's served on the MHC will the T cell recognize it. And so the only way to tell if you have a T cell response is you have to put peptide, you have to get it to be taken up by an antigen presenting cell. The cells have to be alive. You have to culture them in a petri dish in the laboratory, put them in an incubator overnight or for 2 days, get them to respond to the peptide. And the way they respond is by producing cytokines, which are chemicals they produce, interferon gamma, interleukin 2. And then you have to measure the production of interferon gamma or interleukin 2. It's very tedious. And that's the only way to know if a patient has a T cell response. And so one way it's done is commonly, if anybody's heard of an ELISpot, that's these tests of these little petri dish on the top right-hand corner with one is sort of blank and light blue and the other one has little blue spots. Those little blue spots represent interferon gamma production. So that's a little T cell landed there and produced interferon gamma, which reacted with the chemical in the reaction. I'm simplifying, but that creates a blue spot. Another way to do it is by flow cytometry, which is the way this bottom plot here, which is a CD4 and CD8, interferon gamma, TNF alpha, spike, and no stim, is actually done in my lab. There's actually data from my lab, and you can actually you look at individual cells and determine whether it's a CD4 or CD8 and whether they make interferon gamma or whether they make TNF alpha, which is another cytokine. So these are tests that actually we're doing to try to measure the T cell response, because this T cell response is probably the key thing you want to know, not the antibody titer. Okay, there's actually a very, very exciting new method that we're actually exploring with a company called Adaptive, and that actually is identifying T cells by their DNA sequence. So this is the T cell I zoomed in. The T cell receptor is specific. Every T cell makes a unique T cell receptor by taking its DNA in what's called the VDJ region, and it recombines it. Imagine a deck of cards, and it shuffles the deck. And by shuffling the deck, it creates a random assortment. And that randomness is what allows the TCR to respond to different antigens. So you can actually use DNA sequencing to find that DNA arrangement and acts like a barcode. So every cell has a unique DNA rearrangement. You can plot those DNA arrangements in a plot here. So on the right-hand side under subject 6, if you see on the left side of the column, there's a row that's really hugging the left axis that are red dots. These are all clones that were not present. So on what you do is you plot all the clones that were present at before vaccine, all the clones that were present after vaccine. And if there's a bunch of new clones that weren't there before vaccine, they represent the expanded or DNA or responding clone. So it's a very exciting technique. If anybody's interested, I can describe more detailed later on or offline. But this is a way that you can actually count specific responding T cells using a high throughput assay, and might actually allow us to answer the T cell question much more easily. The company is selling, you can order it yourself. It's $150, a test where they will actually, you send in your blood, and you think you had COVID, but you're not sure, you never got tested, maybe you're worried about it. They will actually test to see if you have T cells in circulation. And they show that they can detect COVID T cells in patients when the antibody test is already negative. This is not for patients who are sick, by the way. When you're sick with COVID, this is if like maybe 6 months ago I had COVID, I don't know, and I'm feeling not normal, and I wonder if it's related to COVID. This is the kind of test that could tell you, because the antibodies have already faded. So it's an exciting sort of new development. Okay, so I want to mention this last thing, and this question about cytokine release. So if people have been following the literature, they may have seen this one case report. So the basic short answer is that the vaccines are safe in patients with cancer, mostly because so far we haven't seen anything. But the clinical trials for the vaccine did not include cancer patients. So this is the dilemma. There has been one case report of a patient who was getting a very specific type of treatment called a PD-1 inhibitor. And a PD-1 inhibitor revs up the immune system. And this patient got a dose of vaccination, and they became very sick for a few days, sort of like how you may have felt, but much, much more severe. So not just having the chills and fever, but got very, very sick. But the patient recovered completely. So, but that patient was one patient, and it was a patient who was on this specific drug. And so it kind of makes sense because they're on an immune stimulant. They got a vaccine. They had a severe immune response. It went away. They got better. This is the only case report. So based on this information, we think that, based on our experience so far, we think that it's safe. But when we talk to our patients, we have to be open about the fact that actually all of the vaccine trials, the clinical trials, were done on healthy people, not on patients with cancer. That is actually, there is trials now going on to answer this question in cancer patients. We'll hope to have those data by this summer, but we don't have the data right now. Okay, so that's all I have for you. I have some recommendations and some discussion points that we can talk about. So the first question I already answered: is it safe for cancer patients to get vaccinated? The answer is yes. There have been rare exceptions, but I think I want to emphasize that the mortality of COVID is very, very high in cancer patients, anywhere from 15 to 22% based on the best studies, which is much higher than any other group. So safety and risk is always a balance of risk and benefit. So if there's any group that should get vaccinated, it should be cancer patients, because they have the highest risk of death from COVID. The second question: will the vaccine interfere with cancer treatment? And the answer is no. Other than maybe you feel bad for a day, so don't get it on the same day you're getting your chemotherapy, if you're actively getting chemotherapy. And if you're not getting chemotherapy, then there's no real issue. But it should not interfere. It doesn't affect or interact with their cancer chemotherapy drugs. It just may make you feel bad that day. So if you're getting active chemotherapy, you don't want to have to do it on the same day. So you may not feel like going and getting your treatment. The third question is a real important one. How effective is the vaccine in cancer patients? And the answer is, we don't really know. In some patients, it will not be as effective. We know that from other vaccines. We know that people who are actively getting cancer therapies, especially for blood cancers, do not mount antibody responses. And we know they don't mount T cell responses because of the cancer and the cancer chemotherapy that they get. But we don't know how much. So we know they may not mount much of a response, but maybe a little is better than nothing. Nobody really knows. So what our recommendation to folks is that they get vaccinated, but if they're undergoing chemotherapy, then they have to think of themselves as unvaccinated. So it's kind of like, in one sense, it's the worst of both worlds, but that's what you got to do. So no, what I mean is, get the vaccine, but still practice mask wearing, hand washing, distancing, and everybody that's healthy around that person should be vaccinated. So the term herd immunity is misinterpreted. People think about herd immunity means let everyone get the disease and it'll go away. That's not really what herd immunity is used for in historically. Herd immunity was meant to say that when you have a herd, there's some weaker members of the herd, and if the herd is strong, that person is protected. So herd immunity means if this person who cannot respond to vaccines, everybody around them is vaccinated, then you'll protect that person. So that makes it even more important for the people around the cancer patient to get, the patient should get vaccinated, but assume that they're not going to have an effective response. Should they get tested for antibodies? Sure. I mean, there's no harm to doing it, but we don't know what the level of antibodies is protective. So it just depends on what kind of person you are, is what I tell my patients. If you're a high information person, like information's good, it helps calm you down, then get your antibody tested. If you're a person that it's going to upset you and you're going to say, well, what does this mean? What do I do with this information? Don't test. Because the answer is we don't know. We don't know what level of antibody is good enough. Plus, you might be making a T cell response, which is helpful even if you don't make an antibody response. And then the last question is, should you have a booster shot? And the answer is probably. Probably everyone will need a booster shot. We don't know yet what the schedule is going to be. That's actually actively being studied. But if anybody needs boosters, most likely the patients with low immune response. And when I say we don't know, and it's just because we don't know yet. There are active studies at our institution, at institutions around the country and around the world to determine that. And I showed you that theoretical curve. We are actively measuring antibody and T cell responses in all our cancer patients and healthy matched people. So we're going to know hopefully at 6 months. So the 6-month data just came out for healthy people, and it looks like their antibodies are staying steady and their T cell responses are staying steady. We don't know for cancer patients. And so as we get more information and we see how that response declines, if it declines, then there will be recommendations to do it. I do know of a patient of mine that has gotten 6 different shots. It's doing okay. That's how he deals with the stress of COVID. But probably it's safe. We already know that getting an additional shot is safe. I'm not recommending anybody do that, but if the recommendation comes to get boosters, then certainly that's logical. Remember, other vaccines sometimes need 3 shots or yearly boosters. Influenza, we take that shot every year because the vaccine is actually not very good, and so it needs to have a booster every year. So that might be the case, especially for people with abnormal immune systems due to cancer or their cancer therapy. Okay, so that's all my recommendations in the summary. If there's any questions, happy to take them.
So for people who are watching this, you can submit questions on your screen by clicking the Submit Question button. Dr. Sheikh Gilbay, thank you very much for a very informative talk. There are a couple of questions that have come in already. One question is regarding antibody measurement. You seemed to imply initially that antibody measurement didn't correlate with total immunity, but then at the end, you seem to maybe imply that it did. So do you feel that antibody measurement correlates, or is there any data to suggest that antibody measurement correlates with immunity? So if you have 2 people who are vaccinated, one shows antibodies, one doesn't, is one more immune than the other?
Yeah, so there's a couple of things to sort of dissect, and it is confusing. So what is clear is that patients do not need antibodies to clear normal infection. So we have several patients, anecdotal, who have absolutely no B cells. We've eliminated their B cells using very specific chemotherapy that targets B cells. They have 0 antibody production. And they got COVID and they were okay. They got sick, they got a fever, they were fine. So you can clear COVID without antibodies. So the question is, do you need, but the flip side is that if you have a working immune system, you make antibodies. So it may turn out that actually the antibody is a great biomarker. It tells you that the immune system is functioning. And I didn't get into the details, but you can't make antibodies without B cells. You also can't make antibodies if your T cells are dysfunctional. So although it's not a direct T cell measure, it's an indirect T cell measure as well. So if you make antibodies, it's usually a sign that it's a biomarker for a functioning immune system. So that's one way to think about it. So that's why probably having a good high titer is associated with a good response in a healthy person, in a normal person. The other question is, what is the protective level? So for other diseases that have been around for a long time, we have an estimate of what titer, what level is protective, right? So we will eventually have that information, well, so the way you do the experiment is you'd have to vaccinate a bunch of people and you have to expose them to the virus and you see at what level do you get the disease, right? So that's not really ethical. People wouldn't do that kind of study. Or you do it with natural infection, right? So people get vaccinated against, for example, shingles, right? And we know their titers fall, and we know when then they get the disease comes up. So they can correlate at this titer, people start to have disease again. So then you can determine, okay, this is the level. You draw the line here. Anybody drops below there, you got to get a booster. But that level is no good. We don't know what that level is for COVID-19 yet. So because these assays are still being developed, and they're always relative units. So there's no like absolute number that you need this number of antibody. That's the challenge. That data will come when we have more experience, and if people continue to get it. And then the other confusing thing, and I want to get into that, is that these neutralizing titers are different for each variant, since they're mostly spike. So you can have variant neutralization titers that are different. So these are almost always titers that are then verified to sort of the wild type strain, although there are reports now that different vaccine responses to different variants are different. The antibody titer or response or specificity is different. So it's complicated so far.
All right. Next question. Thank you very much for that answer. Next question submitted online. What if a person has undergone breast cancer surgery in 2011? What are the chances of getting COVID-19? 64-year-old woman asked this question.
Yeah. So breast cancer surgery shouldn't alter your immunity significantly. If you received chemotherapy, it would have at the time, but that's sort of that's pretty far, almost a decade ago. So you should have recovered close to normal. And the chances of getting COVID are, so I should make that sort of clear, just a sort of slight distinction. So the chance of getting COVID are the chances of getting COVID. They're not related to cancer. So you should do everything to not get COVID, which means, not being around people, social distancing, all the stuff that we've heard about. It's the question of, if you get COVID, will you get sick and will you die? I think with that remote history, I would suspect that your risk, whoever this person is, her risk would be similar to her matched cohort. So she is a 67-year-old, which is a high-risk group. So that would probably be the defining factor. But it's impossible. That's why we always show populations. It's impossible to know what any individual person's risk is.
Excellent. Thank you. The next question submitted online is one that I don't understand, so I'll just read it out to you. Great talk. Has your lab looked to see if cytokine production in patients treated with immune checkpoint has an effect on the myeloid cell population, either by CyTOF or single cell? Thanks.
Yeah, so that's exactly what we're doing. So we have about 150 patients in our checkpoint inhibitor cohort. We have about 300 patients in cancer in general. And so we're doing both baseline studies and we're doing full immunophenotyping by CyTOF to look at myeloid, dendritic cell population, B cell activation as well. And we're also doing a whole set, what I just showed you, are stimulation experiments. And the stim we showed you is on B cell, which is T cell stimulation, but we're also actually going to try to measure changes in the myeloid cells as well as the B cells. And with cancer patients, there's this whole, other questions about myeloid-derived suppressor cells. We think of them as related to cancer immune escape, but may also have effects on vaccine response. So actually, we're curious to see if people, like, for example, with high MDSCs at baseline, don't mount a response. So we have this cohort. We're doing CyTOF, we're doing T cell responses, we're doing a single cell RNA-seq on a subset, and we have all their serology. So yes, hopefully we'll have that answer soon.
Very good. Next question. I've had several patients with metastatic cancer who received COVID vaccine and developed bullous pemphigoid refractory to treatment. what issues can we expect with other systems as well?
That's a great question. If you've had several, it's probably reportable. We don't know. Yeah, you should write that up and let people know, because just like that COVID, I showed you that one case report of a patient who had cytokine release. That was the first we heard of it until that case report. I've not seen a case. Certainly, but it's certainly conceivable. We have actually, as part of our study, a big cohort of patients with inflammatory bowel disease, so Crohn's disease and ulcerative colitis, asking the same question, right? Does the vaccine produce a non-specific immune response? Will their Crohn's or ulcerative colitis flare? So far, it looks like no, but there's the only way we're going to know is to gather data. And unfortunately, it's all being done by different academic medical centers. We don't have a central registry, because of where our healthcare system is designed to sort of know this. But it's all going to be post-marketing surveillance, because none of these patients that we treat that are special populations were in the clinical trials. So I've never heard of this, but if you've seen several is worth writing up. It certainly is intriguing.
The next two questions I'm going to join into one for the sake of time, and we're just going to take a couple more questions before we break. Do you have a particular test for T cell response, and do you see clonal expansion of T cells?
Yeah. So you every time you have so the second part. So the adaptive test, the DNA sequence, is exactly that. It tests for clonal T cell expansion because you're recovering the T cells by sequence. So what I didn't get into is in that plot, you're seeing a unique T cell sequence, but you're also seeing its frequency. So if a T cell has clonal expansion, you'll count many more of the same clone, because as they expand clonally, they maintain that same DNA rearrangement. So that's like a barcode forward. So you can actually get clonal expansion. So that's exactly what the adaptive data will show. And yes, patients have COVID-specific clonal T cell expansion. That's exactly what that assay does. The ELISpot test, which looks at cytokine production, does not return clonal information. So if I see in the ELISpot 100 spots, that means that 100 T cells respond. And if I put 1 million T cells in there, then I can calculate that's the frequency of responding T cells, right? But it could be that I have 10 clones with 10 cells each, which gave me 100. Or I could have one clone with 100 cells, or I could have 100 individual clones, right? An ELISpot doesn't tell me about the clonality. And actually, one of the very interesting questions is it better to have a whole bunch of a few clones, or better to have a lot of different clones? Instinct would tell us that a lot of clones is better, because that's where diversity comes in. Interesting aside, everyone's again worried about the variants. Antibodies recognize a larger epitope, so they're more susceptible to variants. T cell epitopes are smaller, and it looks like at least the T cell responses are maintained against all the known variants so far. So a diversity of T cell responses is probably good. But those are very, very insightful questions. They're exactly the kind of thing that we're trying to figure out.
One last question, Dr. Sheikh Gilbay, and then we'll have to break. There's a lot of talk from the various CEOs of various vaccine manufacturing companies about needing booster shots. Based on so much that is unknown about antibody titers, et cetera, how would we be able to know when we need a booster shot? How are they determining that we might need a booster shot? Or are they just trying to sell more vaccine?
Well, right. So I have no stake in this. But yeah, I suspect there's some of the latter. I mean, we certainly all saw the reports of the earnings call where this CEO of Pfizer talked about how much they're expecting to earn on the boosters. Yeah, so it'll be two things, right? It's going to be related to fading immunity, but it's also going to be related to disease prevalence. So if the disease is gone or is at a very low level, then we don't need to necessarily get reboosted because it may disappear. If it becomes endemic and it's there all the time, the way influenza is, then we might need to get boosters all the time. So I think it's two parts. One is fading immunity, and the second is how endemic it is. So it might be what we do is we have specialized recommendations. So this is not my job, but I'm just speculating that we might say that if there's low level, it's endemic at a low level, then high risk populations should be getting the booster. So that's older folks, people with impaired immunity, people who maybe don't get good responses, but probably healthy young folks, people who otherwise wouldn't have an issue and probably have generated a very good immune response the first time will probably be fine. And if you start to see breakthroughs, then you change the policy, right? And if it changes to pandemic level again, that means that's telling you that immunity faded, right? In a sense, the absence of reemergence pandemic tells you that the vaccines are still being effective. The minute they drop, you'll start to see the numbers go up again. So I think a adaptive response. I think the public doesn't like that because it seems like we're always changing our minds. But an adaptive response that is probably region specific to the variance and the prevalence is probably the right answer. But that might not be a good policy, and that's not my specialty. So I'll refrain from opining in that area.
I want to thank Dr. Sheikh Akilbhai Merchant. We're really honored to have somebody of your expertise join us for our inaugural online lecture series. For those people who have questions that we didn't get to or who have burning questions that come up afterwards, please email them to information@sbmedical.org, and we will get them to Dr. Sheikh Akilbhai to answer on one-offs. Inshallah, you will be hearing soon about our next in the lecture series, which will be coming up relatively soon. Once again, I want to close by thanking Dr. Sheikh Akilbhai, but also thanking all of the participants who took part. And of course, doing dua for the long life and health of our beloved Mola, Tabib-e Ruhani, our true physician, and his long life and health. Ameen. With that, we will close. Thank you all very much for joining, and thank you again, Dr. Sheikh.
Thank you, everyone.